Hey, what's up, everybody? How's it going? Welcome to the show. I'm so glad that you are here. I'm just checking my levels real quick, and everything seems to be looking good. The audio should be good. Obviously, that's been something that I've been working on for quite a while, trying to get that audio dialed in. You can't quite see it, but I got a new Rode Video Mic Pro sitting right there. And hopefully the audio is coming in well. So one of the things that I always ask is if for some reason it is not, please let me know. And you can always let me know in the comment section. Okay, before we really get started today, because what we are going to be talking about today is not just balloon pumps, but also Impellas, and really kind of hemodynamics and mechanical support of cardiac hemodynamics. This is going to be just a brief introduction. I get lots and lots of questions about this as it pertains to the FPC and CCPC exam. So for those of you who are in the flight crit community, this is going to pertain a lot more to you. Although those of you in the medic lab community, if you are coming up and are wanting to kind of expand your knowledge, this is still going to be really great information. And there's obviously lots of bleed over. What we're going to talk about initially is I'm going to talk about like kind of the basics, the fundamentals of mechanical support, why we do it, what the goals of it are, and then we're going to talk specifically about the balloon pump, how it works, and we're going to talk about the Impella and how it works and how the two are a little bit different. And then at the end, I'm going to give you some free resources online. They're not mine. They're from the manufacturers where you can go and you can find some more high quality training. There's lots of really good resources out there on YouTube. We've got a mechanical support course as well. But there are two really great resources that I want to share with you that a lot of people don't know about. And frankly, I didn't really know about either until I got into education and doing more mechanical support transports. So with that being said, I want to, first of all, call your attention if you are watching on Facebook, whether it's in the Flight Crit community group or in the Medical Lab community group. Below this post, and I'm actually looking at it right now, there is a, a link. That link, and actually, maybe I can actually share this out. That link, I'll just copy and paste it, and then I will share it. Here we go. I'm going to paste it right in here, share it out, and then I'm going to share that. We should get that. There you go. So this link right here, it is in the comment section of the show right now. If you click on that link, what it's going to do is it's going to temporarily take you to another page. It's just going to ask you for permission to share your screen name and your screen image, as well as a comment that you might make to the show, so that I can display it just like this in the show, and I can, call you out. We can have a conversation, not call you out in a negative sense, but just simply say thank you for the comment and kind of invite you into the show. Okay, with that being said, if you want to do that, please do. I encourage you to. It really makes the show much more interactive and much more exciting. Okay, here we go. I am going to switch over here to just like I was before. So basically, intra-aortic balloon pump counter pulsation, right? What is this thing? How does it work, right? And in order to understand what it is and how it works, you really first need to have an understanding of hemodynamics, right? It's all about supporting the cardiac output, right? So we all think about cardiac output in the terms of how well the heart is working, right? How well the heart is able to eject blood. But there's a lot more to it than just simply the heart beating. And we need to have an understanding of this, right? So cardiac output is a component of heart rate and stroke volume, right? If the heart rate goes up, the stroke volume, if the heart rate goes up, the cardiac output goes up. If the heart rate goes down, the cardiac output goes down, all things else being normal or being the same, right? So stroke volume is where these devices really kind of come into play. And in addition to supporting cardiac output, these devices also improve coronary perfusion. They support peripheral perfusion, cerebral perfusion, right? And we'll talk about that as well. But in order to understand cardiac output, right, we need to understand preload. We need to understand afterload. And we need to understand contractility, right? So fundamentally, I think we all really know what preload is. It's the amount of blood coming into the heart that is available for the heart to contract, right? And we have right-sided preload and we have left-sided preload, right? Right-sided preload and I should probably change that color here. Right-sided preload, venous, and then left-sided preload is arterial, right? Venous and arterial, right? So the right-sided preload coming back from the venous side, right? And it gets ejected out to the lungs where it gets reoxygenated and then comes back into the left ventricle and then gets pumped out to the body. If the right ventricle is not receiving enough preload, then it cannot send blood to the left side. So therefore, the left side preload drops, right? And when it comes to hemodynamics, we've all heard of this left ventricular end diastolic volume, right? LVEDP or LDVDV, or LDVD, left ventricular end diastolic preload, aka the wedge pressure, right? And just about everybody has heard of the wedge pressure. And the wedge pressure is a pressure that's measured in the lungs with a pulmonary artery catheter, but it is an indirect representation of that left ventricular preload, right? If you remember, the pressure is coming back up to the left ventricle into the left atria, and then back to the lungs, and that's how it's able to measure that left ventricular end diastolic volume of pressure. So left ventricular preload, right ventricular preload. There has to be adequate right ventricular preload in order for there to be left ventricular preload or adequate left ventricular preload. Now, you can have adequate right ventricular preload and not have adequate left ventricular preload, and that is because of problems within the lungs, or perhaps it's a right right-sided heart failure, right? So if that right ventricle can't pump hard enough, it can't send the blood to the left, and so you have adequate or potentially over, excess right ventricular preload because that right ventricle is failing, but the left ventricle is dry. All right. So afterload. What is afterload? Right? We think about afterload being the pressure that the heart has to pump against, and there are two types of preload. Afterload. So you have pulmonary artery. I said preload. What I meant is afterload. So pulmonary artery afterload, right? And you have systemic afterload, right? Pulmonary artery or pulmonary afterload, right? That's the pulmonary vascular resistance, the PVR, not peripheral vascular resistance. And then you have systemic afterload or peripheral vascular resistance, right? And so this can be confusing. Both sometimes are abbreviated PVR. One of them is pulmonary. The other one is peripheral. Right? Peripheral being your blood pressure. Right? So important to distinguish these two. The pulmonary afterload or the pulmonary vascular resistance, that is the pressure that the right ventricle has to pump against. And peripheral vascular resistance is the pressure that the left ventricle has to pump against, right? And so with regards to the balloon pump or with regards to the Impella, more so the balloon pump, but also the Impella, we are trying to optimize the cardiac output by affecting the preload and by affecting the afterload. Okay, so let's go ahead and move on. I throw this one in here, right, just as kind of an example, right? Look at this big left ventricle. Do you think that that left ventricle is really doing a whole lot of good in order to pump out blood? Probably not. Big dilated left ventricle, probably chronic hypertension, so years that ventricle is ballooned out. Could be it could be pathological problem with mitral valve. Could be aortic stenosis. There's a whole slew of things that could cause this left ventricle to weaken. Could be an MI. Who knows? But the point is that in this particular case, that left ventricle cannot appropriately move blood forward, right? So we have to assist it. We have to help it. All right, so now let's talk specifically about the balloon pump, right? Intra-aortic balloon pump counterpulsation, right? And this is an important concept to realize that it is a counterpulsating balloon. When the heart contracts, the balloon goes down. When the heart is in diastole and relaxed, the balloon comes up. So let's go ahead and talk specifically about this device, right? The balloon is inserted into the aorta, usually through the right or left femoral artery, and is fed up into, let's see if I can, oh, I can't really do that. It is fed up into the aorta, okay? And it resides right here in, this is looking from like, say this is an image like taken from the posterior, right? So perhaps like a CT through the back, right? Up through the aorta, and then it resides just below the aortic arch here and above the renal arteries. And that's key for positioning, right? So that's one thing that you will see on the exam. How do you know the balloon pump is positioned correctly? Or, you have a patient with a balloon pump in and suddenly their urinary output drops. What would you be concerned about? That balloon needs to be positioned below the aortic arch, primarily the takeoff for the left subclavian artery, right, which would feed blood to that left arm, and above the renal arteries. So if the balloon migrates too high, you lose pulses in the left wrist. If the balloon migrates too low, or if the balloon is too large, you lose urinary output, right? So if you have a patient with a balloon pump and the balloon is, potentially it migrates, you have a sudden decrease in urinary output, think that the balloon is potentially migrated. Another way you can check that is you can check it by, well, you can't really check to confirm if it's moved down, but you might be suspicious. You might also check pulses in the distal extremity. Perhaps that balloon, as it has migrated down, it has moved into a smaller region of the aorta and might be obstructing blood flow to the distal extremities. Very easy to determine if it has moved upward and is obstructing that left subclavian artery is you check a left radial pulse and compare it to the right radial pulse. Compare it to these your pre-transport assessment. Is that pulse weaker? Is the blood pressure still the same? Is the map still the same in this particular case? And how do they compare left and right? So like I said, the balloon will inflate during diastole and it'll deflate during systole. So it's counter to the heart's mechanical contraction. Okay. The goal here is that it displaces blood and reduces afterload and reduces O2 demand, improves coronary artery perfusion. So let's talk about these, right? When does the heart use the maximum amount of oxygen? It uses it during what's called the isovolumetric contraction phase, right? And we've all heard of this from paramedic school. It's during that initial phase when the heart is trying to contract hard enough in order to open the aortic valve. That is when the heart uses the maximum amount of oxygen. Roughly 70% of the O2 consumed by the heart is during that isovolumetric contraction phase. So one of the goals of balloon pump counterpulsation is to make it easier for the heart to open that aortic valve, right? And the only way it can do that is by increasing the pressure in that left ventricle above that of the pressure in the aortic arch, right? Remember, blood moves by pressures, right? So in order for that valve to open, and valves open, by pressure differences, in order for that valve to open, the pressure within the left ventricle during that the systolic contraction phase, the isovolumetric contraction phase, must exceed that of the aortic arch. So right as the heart is starting to contract, this balloon that is obstructing the aorta suddenly deflates. And what happens is it creates a vacuum here in the aorta and essentially creates a negative pressure or a zero pressure, so that that aortic valve can just pop right open really easily, and the heart doesn't have to strain against a pressure in the aortic valve, or in the aortic arch, 120 systolic, 180 systolic, even 90 systolic, right? It doesn't have to overcome that high pressure in order to open the aortic valve. So great, the balloon drops, the heart has no pressure, it has no afterload that it needs to push against, and so the aortic valve pops open, and we get a nice, ejection from the left ventricle, right? We get good blood flow out. So then what happens at the end of systole? Suddenly the heart goes into diastole and the balloon comes up. Well, what it does is it closes the aortic valve, and then it essentially creates a cork. I think the balloon's supposed to occlude about 60 to 70% of the aorta. So it's not totally occluding the aorta, but what it's doing is it's displacing that blood that is within the aorta where the balloon would be placed, and it forces the blood not only retrograde back towards the heart, but also forward to the periphery, right? Down to those renal arteries, down to the peripheral circulation. So it's improving blood flow to the periphery, but primarily by pushing blood back towards the aorta, back towards the aortic valve, back towards the heart, back up towards the coronary arteries and carotid arteries. It's improving that diastolic coronary artery perfusion, right? So if you think about, right, primarily the left ventricle is perfused during that diastolic phase when the pressure within the ventricle is low, right? That pressure can move back towards the coronary arteries and perfuse that myocardial tissue, excuse me, much better. You also get improvement in cerebral perfusion. So the balloon goes down, it makes it really easy for the heart to eject whatever blood is in that left ventricle. And then during the diastolic phase, when the balloon inflates, it pushes blood back towards the heart and improves coronary perfusion, right? So that is the primary function of the balloon pump. It's very simple. There's not a whole lot to it. What you need to know for the exam is kind of the fundamentals of how it works. You need to be able to determine when the balloon pump is misplaced, right? So by loss of left radial pulse, or a decrease in left radial pulse, as well as a decrease in renal perfusion. Those two things will clue you in that that balloon has either migrated up or down. There are some contraindications to the use of the balloon pump that you need to be aware of. So first of all, cardiogenic shock, right? These are the indications. Indications: cardiogenic shock, post-bypass surgery, bridge to PCI, high-risk PCI. So sometimes we'll put this balloon pump in just to improve coronary perfusion during PCI, or percutaneous coronary intervention, in those patients who are just so unstable that they may code when they actually go in to try and perform the PCI procedure. Did not reduce their, that being said, there are some other things here, right? The shock trial looked at these and essentially did not reduce 30-day mortality in these higher risk PCI patients. Post-myocardial contusion, sometimes they will put these in just to support the heart while the heart recovers. And then in these cardiotoxic poisonings, these medications that have a tendency to stunt the heart. We see these sometimes in post-transplants in order to, again, also support the heart. Now, contraindications are the ones that come up big time, right? So aortic insufficiency. If that aortic valve cannot stay closed when that balloon comes up, essentially then what happens is you end up pushing all this blood back through the aorta, back down in here into the ventricle, and you will get increased left ventricular pressures and it can actually cause the heart to dilate and cause all kinds of problems. Aortic stenosis, same thing. So if that aorta is narrow, it causes the same kind of problem. Aortic dissections, that should be a no-brainer. With these two here, as well as severe aortic, really bad coronary artery disease or atherosclerotic plaque. The problem is the balloon is slamming against the wall of the aorta, or potentially in the case of aortic dissections, it's increasing that aortic wall shear forces, and so that's where that's why these are contraindicated, as well as plaque, severe atherosclerosis. Peripheral vascular disease falls into that same category, and then severe coagulopathy. That balloon inflating is going to lyse red cells and lead to further blood clotting disorders. So in these cases, it's kind of a relative contraindication. They'll oftentimes give patients, whatever blood products they need in order to improve the coagulopathic state. And then cardiac index, right? They have to have sufficient cardiac output in order to make this device work. Right? This is a passive device. It's not actively moving blood. The balloon inflates, it pushes blood. So if there's not enough cardiac output, then the device basically is insufficient. And so then they will look at possibly an Impella, or they will look at an LVAD. Patient assessment, I'm not going to go over this. This is something else that you can look at on your own time. But with regards to patient assessment, if you do get a chest X-ray, and you should absolutely get a chest X-ray prior to transporting one of these patients, that tip, the tip of the balloon pump has this radiotranslucent tip on here. And this will tell you where the tip of the balloon is, right? And so it must be at about that second or third intercostal space, to demonstrate that it is below the aortic arch or below that left subclavian artery. And then we already talked about the renal artery, right? So if this balloon, if the lower end of the balloon is too low, right, then you're going to occlude some of these renal arteries, right? And this picture doesn't show really well where the renal arteries take off. They might be up here. It's actually really hard to tell in this picture. But in any case, if this balloon is dropped down too low, then the balloon is going to occlude blood flow to those renal arteries, and you'll have a drop in urinary output. Augmentation is basically how much the balloon pump is helping. I'm going to talk a little bit about timing here in a little bit, but when you are transporting these patients, you are always in a one-to-one augmentation. What that means is the balloon pump is inflating with every systolic and diastolic cycle, right? In 1 to 2, the balloon will only inflate every other heartbeat. And the reason we do that is in order to compare the augmented or the pressures within the aortic arch that are assisted by the balloon with those pressures that are not assisted by the balloon. Okay, and this is why when you look here, this is in a, it doesn't actually say over here, but this is in a 1 to 2 augmentation ratio. And what you can notice is that this waveform is different from the next. All right, so this is, excuse me, this is in a 1 to 2, and this is how you would compare. This is an unassisted, and then this is an assisted. This is a assisted, what is this? This is assisted systolic. No, unassisted diastolic. It's not really easy to tell here, but the point is we can dive more into that in another program and look at how to actually compare these unassisted and assisted waveforms. We're not going to talk about triggers. We're not going to talk about timing. What we do need to talk about, because this is what's most important for your exam, this is what comes up most often on both the FBC and the CCPC with regards to balloon pump transports, is timing errors, right? So there are 4 timing errors that can happen: early inflation, late inflation, early deflation, and late deflation. What I always say is arriving early to the party is bad, but leaving late is even worse, right? So early inflation, not good. Late deflation, even worse. These 2 here, they really don't do a whole lot of damage but to the patient, but they just don't really help quite as much. So let's go through them real quick. All right. Early inflation. What you have here is that the left ventricle is still ejecting blood. That the aortic valve is still open, and then what happens is the balloon inflates too early, and it takes all that blood and it slams it back towards the aortic valve, right? And what happens is it slams the aortic valve closed. It can damage the aortic valve. It is going to cause increased pressures within that left ventricle, and so it's damaging to the heart, right? The way you determine this is that you have an open or a wide V at the dicrotic notch. Okay. If you don't know what the dicrotic notch is, you should. But the dicrotic notch is this little bump when you're looking at your arterial pressure, and it represents closing of the aortic valve. Right. So here you have this is the systolic pressure. Right. The left ventricle has contracted. It has started to relax. The pressures are starting to equal, and then the pressure in the left ventricle is lower than that of the aortic valve. The aortic valve, within the aorta, the aortic valve closes, and when it closes, it causes almost a ripple effect within the aorta. That is this little tiny bump, this extra bump right here. This is called the dicrotic notch. This bump right here is the dicrotic notch. The dicrotic notch is what is used to time the balloon pump. So at the moment of the dicrotic notch, that is when the balloon comes up. That's when the balloon inflates. So in this particular case, we have an unassisted and we have an assisted, right? Remember, 1-to-2 ratio of augmentation. So the nice thing about the new balloon pumps is that they're all automatic, right? There's a computer that can actually detect all of these various components of the waveform, and it will automatically time the balloon pump to inflate and deflate at exactly the right time. But if for some reason that there's a problem with the autopilot of the device, then you need to be able to recognize that something is going wrong, so that you don't just so you're not just oblivious to the device, and the patient is having the device is hurting the patient. So in the case of an early inflation, what you should see, if it's timed normally, is you have this dicrotic notch, and then you have a very sharp, you have the dicrotic notch, and then you have a very sharp upstroke of the augmented diastolic pressure. In this particular case, you get this widened V, or this rounded dicrotic notch. And what this represents is that pressure is kind of trying to prolong. The left ventricular contraction is kind of stretching out that pressure. It's not allowing that nice, clean, crisp inflection of the augmented diastolic pressure. And so this is an indication of early inflation. The other way you can tell is if you were to come across, right? Let me delete this real quick, clear that out. If you were to come across from the unassisted waveform, you would notice that this dicrotic notch is below, this dicrotic notch right here is below this dicrotic notch. The pressure did not have time yet to drop down to the normal level before the balloon came up, therefore creating that nice sharp spike. So because this arch is above the unassisted dicrotic notch, we know that the balloon came up early. Okay. Late inflation, very similar. You're comparing the two waveforms. Here is the dicrotic notch of the unassisted. If we come across, we can then see this dicrotic notch. Then the pressure starts to fall. Then the balloon comes up, and we have a sharp spike in our diastolic augmentation pressure. This is not harmful, but it's also not as helpful as it could be, because the aorta is already draining blood. So therefore, when the balloon inflates, there's not as much blood in the aortic arch to be pushed back towards the coronary arteries. All right, early deflation. The way we know early deflation is we have a wide plateau or assisted end diastolic pressure. Okay, so let's look at this real quick. We're talking about early deflation. What we see here is when the balloon, so here we have the unassisted systolic, dicrotic notch, balloon comes up, we have a very sharp spike. This is our assisted diastolic. Okay, then what happens is the balloon deflates and we have this rapid drop in pressure. This is good. We want this pressure here to be below our unassisted diastolic pressure, right? That means that it's the diastolic pressure in the aorta is much lower and the heart has less pressure to push against. The problem is we then see the blood backfilling, and then it comes up to our unassisted diastolic pressure. Then the ventricle contracts and we have our normal systolic pressure. So basically, we didn't get the benefit of that lower diastolic pressure that the heart has to then contract against, because the aorta backfilled. The balloon deflated too early, which gave more time for the aorta to backfill before the next systolic contraction. So in this particular case, we don't get an improvement in the assisted systole, right? This pressure here, the assisted systole, should be lower than the unassisted systole, right? So even though the unassisted systole would be lower, our augmentation, our perfusion pressures would be higher because of this assisted diastolic pressure being higher. This is the last timing error, and this is the one that's extremely bad. This is late deflation, right? So the way I think of this is, imagine that the ventricle is contracting, right? We know what does damage to the heart is chronic hypertension. So imagine like the worst case of chronic hypertension. The left ventricle goes into the isovolumetric contraction phase. It's trying to squeeze, it's trying to increase the pressure in the ventricle to open up that aortic valve and allow blood to eject, but it has to overcome a pressure that in the aorta that is being artificially increased by that inflated balloon. Imagine it's essentially a cork in the aorta that left ventricle is trying to push against. And until that balloon drops, it's never going to overcome that pressure. So the balloon is still inflated as the left ventricle starts to contract, right? You get a wide diastolic augmentation wave, a wide assisted end diastolic pressure form. So looking back here, what we get is, right, this is our unassisted systolic right here. Then the wave came up. We have the dicrotic notch. The balloon comes up. We get really good displacement. Then what happens is we have this widened, assisted end diastolic pressure. What's happening is the balloon is still up. The pressure in the ventricle is increasing. And so what we don't get when the balloon comes down is this nice crisp drop in the diastolic pressure because the ventricles are already trying to push blood out. Remember, the tip, the pressure sensor is in the tip of the aortic balloon. So it's detecting pressure in the aortic arch. So one of the ways that I think about this is think about like your EKGs, right? If it's wide, it's usually bad, right? So your hyperkalemia, right? Your VTACs, your any of your ventricular arrhythmias, your Wolff-Parkinson White, right? So those are wide EKGs. Same with the balloon pump timing. If it's exceptionally wide, think that there's something wrong. Okay. Early inflation, this is just a kind of recap. Early inflation, late deflation are your two most critical timing errors. Okay. We're going to skip past LVADs, and we're going to talk a little bit about Impellas because there's not as many people who have experience with Impellas. We're starting to see them a lot more, frequently in probably, let's say, the last 5 years. It's percutaneously placed transaortic heart pump. That's kind of the term here. What you have here is essentially the brain that controls think of like a boat, right? If you've spent any time out on a boat, there's a propeller in here, there's a motor here, and a little propeller, and that propeller sucks blood into a port here, and then it ejects it out here. Okay? The way this device works is it sits, it's basically placed frequently through the femoral artery, up through the aortic arch, and then down and across that aortic valve. Here's the inlet port. The outlet port sits just I don't know, would it be distal to the aortic valve here. So what it's doing is it's sucking blood out of the left ventricle, pulling it into this port, and then ejecting it out into the aortic arch. So this does a number of things. It increases cardiac output by actively ejecting blood into the coronary arteries, and because into the aortic arch, and because it is ejecting it right at the aortic valve, just distal to the aortic valve, it is increasing pressure here right at the aortic valve, which increases coronary artery perfusion. Likewise, it is actively offloading the left ventricle. So it is actively sucking blood out of the left ventricle and moving it into the aorta, creating flow, and therefore creating less work for that left ventricle to pump, less blood for that left ventricle to pump. So depending on the device, there's a 2.5 and a 5.0. Those are how much blood they can move per minute. They reduces left ventricular pressure, improves offloading of the left ventricle, increases aortic pressures, reduces O2 demand because the left ventricle doesn't have to work so hard to move that blood out, and then it improves peripheral perfusion. They will use this very similarly to the balloon pump, so high-risk PCIs, cardiogenic shock, unstable angina, and the whole idea is to improve that coronary perfusion and peripheral blood flow and make it easier for the left ventricle to contract. This is what the controller device looks like. It's all kind of run from this touch screen, and then you've got this speed controller over here. The things about this is there's a purge fluid involved. This line that you see here is the purge fluid. It's usually some form of dextrose with heparin to prevent the blood from clotting within the catheter here. And then the dextrose fluid basically ejects out from a little port right here, just distal just distal to where the blood is ejected out. So let me change this color a little bit here. The whole goal here, the motor sits up here. I'll use green. The dextrose fluid ejects out of a little port here, and then as the blood is ejected out of the little port here, it gets deflected away from the Impella motor, so that you don't get quite so much hemolysis. That's the purpose of the purge fluid. So when you pick these patients up, you just need to make sure that the purge fluid is set correct. The other thing to note, I guess there's two other things to note about this particular device. One, this device is not anchored within the aorta. It is anchored at the insertion site, which is usually within the femoral artery. But it is actively, like a boat propeller, trying to pull this device down into the left ventricle. So these devices are at risk, or patients are at risk for what we call catheter migration, meaning this catheter can move into the left ventricle, or it can even float out of the left ventricle. Now, if it moves in or out, either way, if the in-port valve of the device is not in the ventricle and the output port is not in the aortic valve, then it's not doing any good for the heart, right? So the controller unit is able, through pressure differences, is able to tell you whether the device is properly placed, and you'll get various warnings here. The other thing that you need to be aware of is what we call suction events. Suction event. So because, remember, like I said, the left ventricle's preload is dependent on the right ventricle's cardiac output, this device is trying to suck blood out of that left ventricle. And if there's not enough volume, then essentially it will collapse that left ventricle, and you'll get what's called a suction event, where this inlet port, where there's a negative pressure, gets sucked up against the wall of the left ventricle. It can damage the chordae tendineae, it can damage the papillary muscles, and is essentially not going to be functioning. So with these patients, you need to make sure that they have adequate volume. They're what we call preload dependent. So if the patient's dry, give them fluids, give them blood. If that right ventricle is not delivering adequate preload, you might need to give them some pressors to support that right ventricle, so that they are getting enough volume to the left ventricle. There is a right-sided Impella that will draw blood from the right side and eject it across to the left atria. We don't see these very often. Primarily, we see these as a left-sided heart pump. So that's all I have for this presentation on balloon pumps and Impellas. Remember, they just support the heart and they support the cardiac output. The two devices work similarly, or their objectives are very similar, but the way they go about that is a little bit different. So before I end this broadcast, what I want to do is I want to share with you a couple of resources. So there you go. Give me just a minute. Okay. All right. So here we have the Flex Learning, right? So this site here is a learning site. Let me actually go ahead and minimize these so you can actually see them. There we go. All right, so flexlearning.jimdo.com. Anyways, what you should do is just go in and Google Aero IABP class or training, and this site will come up. These are actual training videos specifically from Aero. They are generic in that they give you a good understanding of hemodynamics and the benefits of balloon pump augmentation, early infusion, mountain theory, etc. that you can use to kind of help better understand or kind of better expand on your understanding of balloon pump therapy. So really great resource here. It's all free. The other one I wanted to share with you is from Abio. And this one, you'll want to go on and just search Abiomed Abiomed Academy. You create a profile and it will store your training in the profile. But here you can learn all about the insertion and positioning of the Impella, patient management strategies, additional education, and then here you can learn about more about the actual the heart pump. Here's the Impella 2.5, which is the one that we're seeing most common. So you click on the link, it will take you into their training, and you can open up the curriculum and run through all of the material here. So 2 very great resources for just general mechanical support device knowledge, hemodynamics, and then specifically for the Aero and the Abiomed Impella. I will put the links to both of those in the comment section below so that you can quickly find them. So let's see. With that, see if there are any comments in here. Cool. Well, if you like this, please be sure to share it out with anybody else that might be in your community. And if you like this kind of training, we're going to be doing a lot more kind of premium quality training for members in our Medic Lab, which is a community, which is our membership. It's our monthly membership community where we do kind of more live interactions. We do more comprehensive, in-depth training where you can get continuing education credits. So if you are interested in something like that, you can come over here to flightcrit.com/the Medic Lab and learn more about the Medic Lab. And if you don't have any other questions, then I will say thank you very much, everyone. It sure was a pleasure having this opportunity to kind of go over material with you today. I hope you learned something here. So if you did, please share it out, and I hope to see you on the next broadcast. That's all I have for today. Catch you all later.